Good morning. Welcome to this meeting of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. My name is Dr. Lee Mills, and I'm one of the co-chairs of PTAC, along with Dr. Chini Puliru. Since 2020, PTAC has been exploring themes that have emerged from stakeholder-submitted proposals over the years. Previous PTAC theme-based discussions have focused on topics such as reducing barriers to participation in alternate payment models and supporting primary and specialty care transformation, encouraging rural participation, improving management of care transitions, and using data and health information technology to transparently empower consumers and support providers. At this meeting, we've brought together various subject matter experts to gain perspectives on improving multi-payer alignment in value-based care. We know that this topic is also of interest to the CMS Innovation Center. Before our first session of the day, we're honored to have opening remarks from Ms. Amy Turner, Deputy Director for Policy at the Innovation Center. Ms. Turner brings over 25 years of experience in employee benefits, regulatory policy, and healthcare administration. Prior to joining the Innovation Center, she was Deputy Director of Policy for CMS's Center for Program Integrity, where she was responsible for preventing fraud, waste, and abuse in Medicare, Medicaid, and the marketplace. Ms. Turner began her career at the Department of Labor, where she led numerous HHS, Department of Labor, and Treasury healthcare regulatory teams, including serving as the ACA implementation lead for the Department of Labor and eventually Deputy Assistant Secretary at Department of Labor's Employee Benefit Security Administration. Welcome, Amy.
Well, thank you. I am very excited to be here, although I admit here is actually my basement because it is snowing. I am sorry that I don't get to see everyone in person. I understand for those flying in, it probably ended up being a better call because it would have been horrible, particularly if you were connecting through some airport or something like that to get stuck. Look forward to the opportunity maybe to see people in person next time. That would be great. But I wanted to follow up just for maybe 5 or 10 minutes on some of Abe's remarks from last time when he talked to you in September and talk to you about some of the progress that we've made because I think we have been doing a lot to promote value-based care in ways that are of mutual interest since he spoke in September. So folks may remember when Abe talked last time, he spoke about our strategy, which really just it is a piece of everything we do. We all have it memorized. We all think about it daily, if not hourly. We have 3 strategic pillars. One is promoting preventive care. The second is empowering patients. The third is driving choice and competition. And that is all built on a foundational principle of being careful stewards of taxpayer funds. So what have we done since September? A lot. We actually, in 2025, when Abe came in, he took a very holistic view at the entire model portfolio. And there were some models that were terminated early. There were some where it was a decision made that they would be terminating soon and just to let them terminate because they weren't really showing the results consistent with our statutory mandate to either improve quality while holding costs constant, reduce costs while holding quality constant, or sort of like the perfect scenario, nirvana, which is bringing down costs while improving quality. So there was this very holistic look, and there was a decision made to launch. The hope was to launch 10. We ended up launching 9 new models in 2025. The 10th model will hopefully be rolling out in the next month or two. Those models all fit within those principles. 4 of them were drug models. They all have these really catchy names. Balance, Globe, Guard, and Generous. The drug models very, very focused on trying to reduce costs in both Medicare and Medicaid. Free up those dollars for states, free up those dollars for the Medicare Trust Fund. And speaking of multi-payer alignment, really maybe set some principles and do some things that other kinds of payers can also copy, employer-sponsored insurance, for example, so that the entire healthcare delivery system is benefiting from savings. So there were the 4 drug models. We also did WISER, which is the wasteful and inappropriate services reduction model before he spoke to you. So I'm not going to focus there, but we launched the access model. Access, I think, is really exciting. Like WISER, the idea is to leverage technology to try to improve both care delivery and reduce costs. The thing about access is that it's using technology supported care for people in original Medicare, but the payments are outcome aligned payments. So that I think is really exciting and really new, where the payments are not just a service was performed, pay for it, an item was given, pay for it. They are outcome aligned payments. The payments are tied to actual outcomes. I think that that is a very, very exciting proposition. Earlier this month, we announced a wide range of payers representing 165 million Americans with Medicare Advantage, Medicaid, and private health insurance that had signed on to adopt an outcome-based payment structure that is aligned with the access model. More and more information is starting to come out about how we think that's going to work. We really look forward to hearing folks. Folks have been very active in giving us feedback, and we're looking forward to continuing to iterate with a wide variety of external stakeholders to test access and see how we can make it work in a way that really drives both cost savings and improvements in the quality of care. Another thing I wanted to talk about, MAHA Elevate. This was announced on December 11th, and this is, as its name portends, it is the Make America Healthy Again agenda. The idea, I think, the way I think about MAHA Elevate is we have a lot of ideas. We have a lot of really, really smart people with interdisciplinary backgrounds. They are physicians. We have pharmacists. We have economists, PhD economists. We have lawyers. We have people with all sorts of different backgrounds. But despite the fact that the Innovation Center prides itself in innovating, we don't own all the good ideas. We are very, very aware of that. So one thing we do is we meet with a lot of people and we take ideas, but MAHA Elevate is actually would put money out there, put grants out there essentially for other people to come up with ideas. So this is, I think, a great opportunity to allow others to find ways to attack sort of the root causes of disease and health problems and look for ways for others to innovate with grant money given by the Innovation Center. We'll be taking applications and look for ways to improve health. The last thing that I was going to sort of focus on is the LEAD model, which is kind of the follow-up to the ACO REACH model. So it's kind of, I think of ACOs as kind of the bread and butter of the Innovation Center. But what we're trying to do there is just constantly improve, constantly iterate. So the idea behind LEAD, I think, is to sort of, well, there's a lot of different ideas, but one of them, and one I want to focus on with this group, since we're talking about multi-payer alignment today, is really to emphasize on the integration of Medicare and Medicaid services, working with our partner states to develop a framework for ACO Medicaid partnership arrangements. I think that that is very exciting. There are a lot of people who are duals, near duals. I think there are a lot of opportunities there. So those are some of the things that we did in 2025. There were a rush of them at the end of November and in December. And there is a lot more that we have plans that I am sworn by secrecy I can't talk about, but I think there will be a lot more, roughly the same number of models we announced in 2025. I expect there to be on or about a similar number in 2026. Some of those models will be finalizing rules. For Globe and Guard, they were rulemakings. We did a notice of proposed rulemaking. Same with IOTA kidney care model. So we'll be looking to finalize those in 2026. But there are also other things that we are very energized about, very excited about, and we'll be looking forward to make announcements in 2026. So appreciate thinking and talking and discussions you guys are going to be having today. We have a lot of our team that are going to be listening in and doing other presentations and looking for ways that we can collaborate and share all of our learnings and make sure that what we're doing is sort of putting out the best ideas that we can and making sure that we're leveraging the multi-payer alignment to have the most sort of bang for our buck, thoughtful and well-constructed approach to improving healthcare delivery. So with that, I think those were most of the things that I planned to talk about. I want to thank you in advance for your time. I think it is a really, really, really important goal and agenda and sort of mission that we all share, which is to bend the cost curve, frankly, and do something about the fact that currently in this country, we are throwing massive amounts of money at healthcare while getting, my words, kind of mediocre results. Compared to other OECD countries, we don't live as long, we don't live as well, we throw a lot of money at the problem. So working together, I think we can find ways to turn that around, and do a better job for Americans. So thank you for having me here today. I will be in and out throughout the day listening to some of the conversations that you're having and really appreciate the work that you're doing. Thank you very much.
Wonderful. Thank you for sharing those remarks, Amy. We appreciate your continued collaboration and support and engagement, and we look forward to continuing our collaboration with the CMS Innovation Center moving forward. So thank you for those remarks. For this public meeting's agenda, we will explore a range of topics on improving multi-payer alignment in value-based care, including perspectives on multi-payer alignment across programs within Medicare, lessons learned from state value-based care models that have implemented multi-payer alignment, and addressing challenges to advance multi-payer alignment. This public meeting will focus on direct multi-payer experiences with the goal of identifying practical, actionable steps, lessons learned, and innovative approaches that CMS and other stakeholders can apply to advance and operationalize multi-payer value-based care models. The background materials for this public meeting, including an environmental scan, can be found on the public meeting registration site and will be posted online on the ASPE PTAC website's meeting page and the public meeting registration site. Throughout the meeting, we will hear from many esteemed experts with a variety of perspectives. I want to mention that tomorrow morning will include a public comment period. Public comments will be limited to 3 minutes each. If you would like to give an oral public comment tomorrow, but have not yet registered to do so, please email ptacregistration@norc. Again, that's ptacregistration@norc.org. The discussion, materials, and public comments from this public meeting will form a report to the Secretary of HHS on improving multi-payer alignment in value-based care. Over the next 2 days, the committee will discuss and shape our comments for the upcoming report. In December, we posted a request for input on the ASPE PTAC website to give stakeholders an opportunity to provide written comments to the committee on improving multi-payer alignment and value-based care. And to date, we have received 4 responses that the committee may consider during their discussion time. I would also like to note that, as always, the committee is ready to receive proposals on possible innovative approaches and solutions related to care delivery, payment, and other policy issues from the public on a rolling basis. We offer 2 proposal submission tracks for submitters, allowing flexibility depending on the level of detail of their payment methodology. You can find information about submitting a proposal on the ASPE PTAC website. Lastly, on behalf of PTAC, I'm pleased to share that the committee is now producing a series of issue briefs that summarize the latest information and evidence related to value-based care that the committee has explored, along with the input of experts at the public meeting. Currently, 6 issue briefs, along with highlights from PTAC's 2020 through 2025 theme-based public meetings, are posted now on the ASPE PTAC website. The committee will be publishing new issue briefs on additional topics in the near future. At this time, I'd like to invite my fellow PTAC members to please introduce themselves. Please share your name, your organization. If you'd like to, feel free to describe any experiences you have with our topic. I'll start out. I'm Lee Mills. I'm a family physician. I serve as Chief Medical Officer of Aetna Better Health of Oklahoma, one of the state's 3 contracted managed Medicaid plans. I spent 25 years in healthcare and medical group operations and had the pleasure to practice within, guide or lead approximately 6 CMMI innovation models over the last 20 years. Next, we will turn to Henish.
Morning, everyone. My name is Henish Bansali. I'm a primary care physician by training in internal medicine. Spent about 15 years working in value-based care on the inpatient, outpatient side, most recently as Chief Medical Officer for Medical Home Network, prior to which I was at Dooley, DuPage Medical Group, as their Senior Vice President for Medicare Advantage and ACO REACH. Prior to that was at Oak Street Health, before that at the University of Chicago. I think the next person is Lindsay.
Thanks, Henish. Good morning. I'm Lindsay Botsford. I'm a family physician in Houston, Texas, where I continue to see patients, including Medicare beneficiaries, as a PCP, and serve as the Regional Medical Director for the Midwest and Texas for Amazon One Medical. I've been working in ACOs and value-based payment models for the last 15 years, including currently as the chair of the governing body of the Iora Health Network, our ACO REACH entity, which is continuing to produce savings over the last couple performance years. Pass it to Walter.
Good morning, everyone. My name is Walter Lin. I am a practicing physician, founder of Generation Clinical Partners. We are a medical group based in St. Louis, focused on the care of frail, expensive Medicare beneficiaries living in senior living. I'm also the Chief Clinical Strategy Officer for LTC ACO and a Medical Director for our PACE program as well. I'll go ahead and pass it over to Larry.
Good morning, everyone. I'm Larry Kaczynski. I'm a retired gastroenterologist. I practiced for 35 years in the Chicagoland area, building the largest GI in Illinois, the Illinois Gastroenterology Group. Submitted one of the very first PTAC proposals back in 2017, Project Sonar, which was ultimately recommended for testing by the Secretary. What Project Sonar did launch was a Sonar MD, which has taken the same value-based initiative and applied it in the commercial space. We are in multiple Blue Cross plans around the country, and it's now been active since 2020. I am also the fractional CMO for a startup, Jonah, which is a AI-powered microbiome company. And then finally, my most recent initiative is a company named ViaVoc, built around a patient monitoring device, which you can think of as an olfactory Alexa. I've been on the committee for 5 years. I look forward to the next 2 days. And I will
Lauren?
pass it on to, Lauren. Okay. All right.
Good morning. I'm Lauren Harden. I'm a nurse by training and Chief Integration Officer for HC2 Strategies. HC2 is focused on building healthy, connected community approaches to complex populations. My current work involves a lot of cross-sector integration, bringing public health, health systems, counties, states, and community-based organizations into integrated models to serve those with the highest needs. My background has primarily been focused on complex populations, originally designing care management and multiple value-based payment arrangements, as well as leading an all-payer complex care center model that scaled, was very successful, and was recognized by the National Academy of Medicine and the American Academy of Nursing. I joined the Camden Coalition and was part of the initial team to start the National Center for Complex Health and Social Needs, scaling models for complex populations across the country with multiple partners. And now I'm working deeply in that cross-sector work as well as innovation in Medicaid. I will pass it on to Krishna.
Thanks, Lauren. Krishna Ramachandran, Chief Information Officer for United Healthcare. I've spent 24 years in healthcare from a technology, provider, and payer perspective, most of it furthering value-based care, and spent a few years in the multi-payer alignment work as well. Yeah, good to be in this meeting, exciting topic. I will pass it on to Josh.
Good morning, everyone. Josh Lau, internal medicine physician. I've had the pleasure over the last decade or more to work on alternative payment models and value-based care and population health in a number of different ways, including leading a portfolio of research, engaging with state and other policymakers, including states that have had multi-payer initiatives and alignment, and also kind of having system roles related to population health and payment and care delivery redesign strategy. Currently, I am a national AVP for clinical transformation Ascension, where we target Medicare and other Medicaid and populations with technology within a policy framework, including those related to APMs, and also professor at the University of Texas Southwestern Medical Center. I believe that's to
David.
David.
Did you say David? Okay. Yeah, good morning. David Tyson. I'm at Novant Health. I'm the Senior Director of Public Policy. I believe I'm the newest member of the PTAC and also one of the few non-physicians. So happy to be with you all and look forward to getting started with the PTAC moving forward.
All right, thank you all. Now let's move to our introductory presentation. PTAC members, you'll have an opportunity to share any comments and ask follow-up questions after the presentation. 4 PTAC members served on the Preliminary Comments Development Team, or PCDT, which has collaborated closely with staff in preparing for this meeting. Josh Lau was the PCDT lead, with participation from Lindsay Botsford, Lauren Harden, and myself. I'm thankful for all the time and the effort the PCDT put into organizing today's agenda. The PCDT will share some of the findings from their analysis to set the stage and the goals to frame up for the meeting. I'll turn it over to Josh. Take it away.
Thanks, Lee. And as Lee mentioned, I am one of a few members of the PCDT, and even though I am holding the proverbial microphone, a number of people and effort went into this report, not just Lindsay, Lauren, and Lee's time, but also staff from HHS and our partners at the NORC. I wanted to extend a word of gratitude to them. Without their effort, we wouldn't be able to present what we're having here in this presentation. So next slide, please. So I think just to give you a sense of where I'd like to go over the next 30 minutes or so, I want to begin with this idea of why are we here online at this meeting, and why does PTAC care about this topic of multi-payer alignment? And then we'll zoom out from there, and kind of start with a why purchase and begin with the proverbial end in sight. I think many conversations about the healthcare system often begin with what's broken and what needs improvement, and that's important, and we'll give that treatment. But I think beginning with the outcomes that we want, both in the ideals, but also for patients, not just what we want for models, but also for markets and communities, I think is important. So we'll begin there with vision and value, and then we'll kind of back our way in this conversation to then think about, if that's the vision and the value of multi-payer models, what might components of high-functioning models look like, identify some challenges along the way. And while that concept is really good, I think it's also important to ground it in what's happening now. What have we learned, so to speak, from the ground? So where have we seen public and private initiatives converging? What's real, what's aspirational still? We'll talk about those initiatives. And then finally, just to kind of come back in, we'll preview upcoming sessions that we have with some of our subject matter experts over the next day and a half. So with that said, maybe a next slide, please, and we'll jump right in. So the reasons and objectives for this theme-based meeting, I think, one is to identify successful approaches and solutions for overcoming barriers to multi-payer alignment in value-based care. And we mean that widely, not just with federal or state models, but also across public and private payers. Again, those ideas are great, but really identifying what are some concrete short-run steps to get us to that alignment that we aspire to. But then still finally keeping our eye on this long-term goal of alignment. Alignment is not just getting quality measurement set up or a playbook, but it is much bigger, much broader, and ends with the health and better outcomes for patients and communities. So those are our objectives here. Next slide, please. So why does PTAC care? We have spent a lot of time and a lot of deliberation over a number of meetings over a number of years looking at different proposals. And you can see there of 36, 28 of those have been deliberated in our public meetings like this one today. And committee members have found that 14 out of 28 proposals have included potential approaches that either focus on or relate to multi-payer alignment, which is to say that a large proportion of the committee's work has focused on things that relate to multi-payer alignment, and this issue is very salient to us as a committee. Next slide, please. So again, next slide, please. We'll start with the vision and value of these multi-payer models. So as a level set, how are we approaching this word? I think oftentimes, we say the same things, but don't always mean the same thing in conversations like this in the policy and practice and health community. So PTAC is working off of this definition for multi-payer alignment. I will read this word for word, just so that we are all kind of level set here. So we are conceptualizing multi-payer alignment as agreement among payer programs and products, including those offered through traditional Medicare, Medicare Advantage, Medicaid fee-for-service and managed care, commercial insurers and employers on model alignment areas necessary to promote value-based care. Model alignment areas in this definition include but are not limited to the goals and strategies, care delivery, financial incentives, quality measures, and data sharing. And while I think this was our attempt at being thoughtful about how we define multi-payer alignment, we do want to acknowledge that this will continue to evolve as we collect information from stakeholders. Next slide, please. So why multi-payer alignment? At the risk of kind of stating the obvious, it's important to surface this regardless that value-based care can help improve population health, which is the reasons to launch models like those you heard from Amy and those have come before it, and to reduce spending growth. However, the financing landscape remains a mix, not just in kind of the different payers in that landscape, but also the mix of incentives such as fee-for-service or value-based care incentives. If those are the design and the incentives, also the implementation has variation across program and payer. And so this concept of alignment becomes very important for us to address these issues. It's hard to address these first two bullets without really thinking about alignment. Next slide, please. So, what are some of the potential benefits of multi-payer alignment? More collaborative work and alignment between providers and multiple payers serve to yield a number of benefits, including stronger care pathways for disease prevention and management, more time to focus effort on care transformation, greater data sharing, and more informed clinical decisions, lower costs for investing in capabilities to improve care, and less administrative burden and costs. Again, a number of things that perhaps many of us that are tuning in today have known, felt, have maybe lived in our jobs and responsibilities. Certainly, these are many areas that the PTAC has discussed, but all relate to multi-payer alignment. Next slide, please. So a little bit of a taxonomy here, because again, I think a word and a concept as big as alignment can be hard to really talk about concretely. So, we as a PCDT identified a few different dimensions of alignment that are worth highlighting. The first, perhaps most obviously, is the types of alignment. I think most people and groups think about this as across payers, but we wanted to highlight that not just alignment across different payers, but within payers. So recognizing their different products and programs within each payer, alignment there is very important as well. Perhaps a little more pragmatic in terms of whether it's achievable, but relevant here. Beyond types, we think of an extent of alignment. So are we talking about the number of programs or payers involved? That's one way to measure extent. Other ways include the level of payer involvement. So number of staff involved, length of time a payer is engaged in a multi-payer initiative. And then another might be geographic spread of patient populations within payers engaging in multi-payer initiatives. Beyond types and extent, we've also conceptualized degree of alignment. So thinking about things that are exact versus directional. Exact being agreement or alignment on specific details of a model. And we'll get into this in subsequent slides. Very important, but challenging given goals and very time consuming, as opposed to directional alignment, which is that we agree in direction of certain measurement or certain goals or care delivery strategies or incentives, but maybe not matching up specifically in the details. So different types, different extent, and different degrees of alignment, I think, are relevant. And I hope this provides a scaffolding for everybody here as we go into our sessions and deliberation. Next slide, please. So bringing together kind of how we are going to spend the next 10 to 15 minutes, a lot of the things I've talked about in the last few slides really live on the right side of this slide. So, what are the outcomes we want? Again, better outcomes for patients, less administrative burden for providers, benefits to payers and different stakeholders. But that's one thing to say outcomes. Look at the left part of this slide. To get there, what do we need? Well, we need payers and multiple payers. There are a number of critical stakeholders, patients and populations being one, but providers, purchasers, convener organizations that facilitate value-based care being others. And then these payers and stakeholders then kind of flow into a number of factors that live out in the environment. So engagement of stakeholders, market circumstances, certain regulation related to competition, and trust, facilitator involvement, et cetera. And then it gets into the technical aspects of model design. If we want a model that's aligned across payers, not only do we need to align in the who's at the table and the stakeholders that inform these models, but also, the goals and strategies, the care delivery specifics, methodology for payment and incentives, measurement of quality, attribution, benchmarking, risk adjustment, data interoperability becomes very technical and very pragmatic in some ways. And so we wanted this slide to represent both the aspiration and the goals, but also the technical details that we need to land in order to get there. So I hope this is kind of a framing piece for us as we keep going here. Next slide. Getting into those components, one more slide forward, please. This will put words to some of the things you're seeing in that conceptual diagram slide, but in more detail. So when we think of stakeholders, we think of that in a broad sense. As I listed earlier, payers, providers, purchasers, and employers, patients and state agencies, and also municipalities. These are all different groups that we need in collaborative design, implementation, and evaluation of multi-payer models. Perhaps more than any topic that is relevant in value-based care and alternative payment models, when you think of multi-payer alignment, the necessity of having multiple stakeholders is essential, right? And in that, one of the outflowings of that essence is a governing body that oversees activities, promotes transparency and accountability. The governing body would be benefited by a trusted facilitator, such as a convener. That might be a state entity. It might be a different type of group that's put together. But the key idea is that facilitators kind of balance and align competing interests, manage expectations, facilitate collaboration among payers as well as stakeholders. And then having measurable goals is really important to monitor progress and ensure engagement. Next slide, please. So as I mentioned earlier, there are aspirational ideas of multi-payer alignment and initiatives, but there's also technical aspects of it. And so having technical assistance for those who need it is very important. We give an example here of how CMS has supported facilitated learning collaboratives to share best practices in different models and different initiatives. And I think some version of that is going to be important for any future models that we were to recreate. Consideration of characteristics and needs of different patient populations and providers. I think that goes without saying, but is worth still bold-facing and highlighting here that really understanding we're solving for patient populations and clinicians and delivery organizations that take care of those patients is important. We're not designing alignment in a vacuum. And then I think having a common payment model with things that are standardized to the best we can, whether that be rates or enhanced transparency or ways to reduce provider burden, I think become very important as well. So just a few more kind of technical and pragmatic components of this. Next slide, please. Just continuing on here, flexibility. So while we want standardization and kind of systemness, we also want to provide flexibility in structuring payments to accommodate different really patient population as well as provider and payer needs. When we think about the other things I've showed you on that conceptual diagram slide, performance and quality measure alignment, things like attribution, benchmarking, risk adjustment, data interoperability, health information exchanges, again, things that you see on this slide here, these are all really successful components of successful multi-payer and aligned models. And as we'll get into over the next day and a half, really require a lot of effort to design intentionally and thoughtfully. Next slide, please. So if we've talked about the vision and the value, the vision is really improving the health of our patients and communities. And the value is not just for those patients and communities, but also for the providers and the payers and the purchasers, public and private. If there are values there and there are benefits there, and the components are what I listed out, both aspirational, but also technical, related to a number of areas. What are some of the challenges standing in the way? Why don't we have multi-payer models suffusing our community left and right here? And so I'll spend a few slides talking about that. So most fundamentally, perhaps payers may have different goals for payment models related to the things you see there. I think affordability and quality and population health, reduce disparities and reduce provider burden are all agreed upon goals. How we get there, though, becomes a little bit different, and how for different patient populations and communities these might be weighed against each other's may vary. Achieving exact alignment on model areas can be challenging as a result of that, because of the differing needs of patient populations and really organizational priorities. And so, this is where we talked about exact versus directional alignment. Perhaps in these cases, directional alignment can allow different participants and payers to align, but tailor those care delivery approaches within a payment model to enable and facilitate flexibility. And getting exact matching on attribution, benchmarking, and risk adjustment may then be less feasible, and allowing variation there as long as things are directionally aligned may be potentially useful here. Next slide. Other challenges, I think you can see here, significant financial and technical barriers that the PCDT identified and want to surface for discussion here today related to data sharing and who bears responsibility to develop solutions for that. Payer measure sets. Measures themselves can be different, but then access to measure sets may be uneven because of proprietary sets, and that in turn impedes broad use and standardization using measure sets. And when we think about kind of delivery organizations and clinicians, their existing billing systems and other kind of processes that they use may be difficult to adapt across payers and multi-payer engagements. And then workforce shortages, and churn. It's easy to design these models assuming that we have the individuals and the teams and the units that we need. But as we know from other prior PTAC meetings and other sources, that's not true, that shortages and churn can really make it challenging for delivery organizations and clinician groups to navigate all these processes, even in a single payer initiative, much less a multi-payer one. Next slide, please. Just a few more challenges here. Again, as I alluded to earlier on the conceptual diagram slide, some things are challenges within a patient population or provider group, but also thinking now about more broadly, what about competitive market conditions in a region? What about community needs in that region? Specifically thinking about, is it practical to customize models and multi-payer models within markets of large or small scale, including particularly small market areas? And then thinking about, payers' willingness to engage in these initiatives, how they're influenced by market share. You see here payers, we've identified that payers with a dominant market presence may be more likely to steer decision-making. Payers without that dominant presence may be less likely to benefit from those improvements. I think it's also important to note that in markets where competition is the strategy, alignment here really highlights some of the challenges in getting alignment across payers. Next slide, please. Federal antitrust laws restricting collaboration among payers to do the things that would be required for multi-payer alignment are really notable. You can see a few kind of sub-bullets that we've highlighted, how certain initiatives at the state level may be eligible for immunity from certain laws, but that non-state-led initiatives may need to work around some of these things and acknowledge them. We've highlighted anti-kickback and Stark laws as specific examples that prevent certain care processes like referrals that involve kickbacks and financial benefit that may impede the types of kind of patient flows and interactions and coordination that we may want. Critical laws, very important for integrity and regulation, but how does that interact with some of the goals of payment models that we may want to see, and in particular multi-payer ones? Next slide, please. So we spent some time again just talking about where we want to go, what are the components of the aspiration around multi-payer alignment, but some of the challenges therein. I want to spend the rest of our time, the bulk of it, talking about what's been done over the preceding years. This is not a blank canvas. Many entities have engaged and participated in some of these initiatives. And so what have we learned from them? What are some of the results? And how can that inform how PTAC listens to and engages with our subject matter experts over the next day and a half? Next slide, please. So here what we're looking at is kind of the broadest catchment, at least we found in the PCDT assessment, related to multi-state, multi-payer models and initiatives. And many of these are led by CMS as really a leader and a vanguard in this space, and with a unique position to convene and engage a number of public and private groups to do multi-payer initiatives. So you can see a number of models here on the left side. I won't read them all to you here, but they encompass a number of different programs related to primary care, state-based transformation collaboratives, and innovation models. There are a number of years. You can see some of these models date back to the early 2010s. Some are currently present or span into the next decade. Look at the right side of the slide here, payer participants, with a few exceptions. Many of these touch Medicare, Medicaid, and commercial, so are really intent and designed to be a multi-payer in the broadest sense. So I think what I take away from this slide is that there has been a lot of work over many years engaging a number of payers to do multi-payer models. Next slide, please. So some accomplishments and lessons learned, and this is really not so much about kind of the impact and the outcomes. We'll get to that in a few slides, but really about, if stakeholder engagement, a governing body, a facilitator, making sure we align in some way, to some extent, to some degree, on the goals and the strategies. If that's the goal, then what have we learned about that? And you can see here that some are too early yet to draw conclusions from, but I think some of the themes you can see highlighted in the bold-faced text are that a blueprint to kind of memorialize and articulate multi-payer alignment becomes important. And, kind of thinking about ways in which when goals are not aligned, you might have limited payer participation alignment in a program such as PCF. As you see from CPC Plus at the very bottom there, again, kind of facilitating data aggregation facilitated by a neutral convener, and kind of bringing all lines of business together and aggregating data into a single tool. I think you're seeing a coming together of very specific things like data aggregation, but undergirded by a blueprint, convener, and kind of a governing body. Next slide, please. Just to kind of emphasize that point, again, from the SIM initiative, we saw really that relationships are everything. You heard a little bit about the pledge that Amy Turner mentioned earlier about groups that have signed on related to the access model. I think, there are echoes of this in prior programs related to relationships, and establishing a pledge and an alignment around the need for multi-payer alignment becomes really critical. You can see this concept of relationships kind of cascading through programs like CPC as well. You begin to see recurring themes around single tools, bringing different groups together to use the same tools or take the same approach. But that collaboration, trust building, all kind of takes time, and is complex, and but is critical to these initiatives. I think that's what I take away from this slide as well. Next slide, please. So if that was kind of in the how do we convene, how do we govern, how do we build trust, how do we get alignment about where we want to go, we also wanted to be very pragmatic here about some of these models that I showed you on prior slides. What are some of the results? And so you can scan the right column here to look at the results. I think in some cases you can see that there was some effect. In other cases you can see there was a minimal effect. In some cases there were effects in certain regions and not others. And I think, again, there's a lot to go row by row. We won't do that because each of these models had very specific design elements that are relevant to the PTAC. But if we kind of aggregate it for those of us on the call today, what are the themes I take away from this slide? I think number one is that multi-payer models have potential. That's what I take away from this. Number two, success is not guaranteed in the outcomes that we want. Third, I think if you put this with the slides you saw before, sometimes when not enough time was given, when the complexity of alignment and governance and shared tools may not have been given enough time, that may impact success versus failure in certain areas. And finally, you can see that certain areas had certain outcomes versus others. And I think that reflects, again, the market and community factors and the patient population factors that come to bear. So I hope this kind of brings to life what we've been talking about over the preceding slides, that there is potential, there are challenges, and the factors that we've identified in our conceptual diagram and in the preceding slides really come to bear on this. Next slide, please. So if that was multi-state kind of broader initiatives, I just want to highlight that as a kind of complement to that. There have been a number of state-based multi-payer initiatives, and a number of these models have also been supported by CMS. And you can see there in different flavors: CMS Innovation Center models, SIM awards, state transformation collaboratives, really focused on individual states. And that while a number of states have engaged, we are going to focus on the subsequent slides on 9 states that you see listed here that have taken what we consider substantial work implementing multi-payer models and initiatives. Next slide, please. So again, a busy slide, but it kind of lists initiatives from those 9 states. And I think the key takeaway qualitatively from this is that, again, spanning a number of years, dating back more than a decade in some cases, but engaging a number of payer segments and payer participants in these models. So a number of lessons that we can learn from and kind of plumb the depths of to understand more from these models. Next slide, please. So just kind of getting into, again, the lessons learned, kind of mirroring a few slides ago from the multi-state initiatives. If we look at state-based multi-payer models, you can see kind of, again, I'm drawing some qualitative things out from a busy slide, but just to say that, buy-in and engagement become important from stakeholders. Here you're seeing in the Arkansas case, the governor, as well as Walmart as a large private employer. Getting stakeholder consensus within the state becomes important. And ensuring that as they move forward, simplifying the design process to allow those stakeholders to engage were some of the lessons. The California Advanced Primary Care Initiative, I interpret to have a similar concept around inclusion of independent practices. It is a reflection in my mind that different states have different stakeholder groups, and it looks different, but engaging as many of them as widely as possible becomes critical. And again, one more time, just to kind of underscore yet again, in Colorado, thinking about a broad range of stakeholders and the need to align across plans, including national health plans, some of the lessons learned from the APM alignment initiative. Next slide, please. So continuing on here, Maryland, Minnesota, Pennsylvania, again, 3 more state-based models. And I think they highlight, again, the highs and the potential lows of multi-payer models here. So you're seeing similar themes: partnerships, setting groundwork, making things, make sure that there's engagement, alignment there, broad stakeholder group in Minnesota, for instance. On the other side, you're seeing things related to, what are some barriers? Lack of clear goals, the market conditions that create a competitive nature between plans. When it's time to then land the technical aspects of things, how to actually do that for different providers, such as rural hospitals versus not, and the real things related to predicting global budgets and those technical aspects that have become certain challenges that we've highlighted. Next slide, please. Rhode Island, Vermont, and Washington, just 3 more that we'll highlight from this group of state-based initiatives. I'm beginning to sound like I'm repeating myself, but I hope that the repetition underscores the critical nature of some of the themes that we're highlighting here. But I think you're seeing, again, where you see successes, it's engaged leadership, it is clear attainable goals, it's multi-payer alignment. In the case of Washington at the bottom of the slide, it is developing and getting kind of buy-in on memorandums of understandings and collaboration about what different payers are trying to solve in these types of initiatives. And then there are kind of elements of the technical design. Do you make this voluntary, or do you mandate participation? How do you fund these initiatives? And so lots of specifics around this broader alignment work that each of these states seems to represent in some way. Next slide, please. So I want to pause here. I've covered a lot in a relatively short period of time, but I hope this presentation has helped kind of set the proverbial table around why does PTAC care about multi-payer alignment? We do because it's critical to the work that we're mandated to do. What is the vision and value for patients, populations, communities, as well as providers and payers and public groups like CMS and state Medicaid agencies? I hope that's clear. We are not working in a vacuum. There are components that we have identified from initiatives that exist, but also from published literature and from our collective experience. There are components of successful multi-payer initiatives, but there are a number of challenges that dot the path to those goals. And again, these are informed from a number of statewide as well as multi-state initiatives that have been implemented over the last 10 to 20 years. So with all that said, I want to just preview what's coming in the next day and a half. So if you can go to the next slide, please. We'll start talking about perspectives on multi-payer alignment across programs within Medicare. So again, our definition being broad enough to think about products and programs within a payer. I think we'll begin there with Medicare as an example. And then we'll kind of shift to thinking about state-based models that have implemented alignment. Many of the examples that you saw from the slides talking about lessons learned and outcomes, we're excited to hear from stakeholders and different groups about that. And then we'll also talk about challenges in taking us from where we are now to where we want to go with advancing multi-payer alignment. So a really exciting next day and a half. I look forward to learning from them and to the deliberation from the committee. Here I'll stop and maybe pass it back to the PTAC chair.
Wonderful. Thank you, Josh. Appreciate that really cogent, clear outline of where we are and where we're going the next 2 days. Before I open it to the full committee, any PCDT members have additional comments to add?
I'll just jump in with one comment. Josh, you did a fantastic job. Having been involved in multiple of these models across states, I'm really interested in hearing from our experts about even when you get the financing right and the measures right, the culture change can sometimes be the hardest to implement. So really hearing what facilitated that within payers, within delivery systems, and within communities to really move the dial from fee for service to value-based.
All right, other committee members, comments or thoughts? Well, I'll offer that I was struck during the PCDT's work, as you look at all that's happened in the last 20 years around multi-payer alignment, that multi-payer alignment truly is necessary, if not wholly sufficient, of course, by itself. It's like, as we've heard in the last meeting or two ago from CEOs and CFOs of major national health systems, essentially, that it takes multi-payer alignment to have enough volume of patients and populations involved, enough revenue involved to get their attention, to be willing to change the machinery of what the health system delivers every day. From a provider leadership perspective, medical group perspective, an initiative that only affects 5% or 10% of your patient population doesn't change the culture of how, or the mechanics of how group practices. So multi-payer alignment really is the necessary, very narrow, thread the eye of the needle step to actually get leadership on board to fully engage. CMS, of course, is in a very unique position with classic Medicare, MA, ACO, Medicaid, of being able perhaps to move the needle themselves, but we've seen in many of these multi-state initiatives that having commercial payer involved is really critical. Larry.
Great job, Josh. It was so clear. I enjoyed the presentation. You used the word at the closure of your presentation, the word mandate. And, we have a mandate, but I'm going to really look to see how many of our subject matter experts feel that we can do this on a voluntary platform, or whether we're going to have some type of a mandate in order to get buy-in from all the groups. It may be necessary. We'll be able to. I'm going to be curious to see how everybody approaches.
Other follow-up questions or comments from the committee? We've got about 5 minutes left for a planned break. Any other follow-up questions or comments? All right. Amazing job, Josh. Great setup for the next 2 days. Seeing no further comments or questions, we will go ahead and move to our break. We will return and start fresh with the live public meeting at 10:40 Eastern Time. Please join us at that time as we welcome a great group of experts for our first session on perspectives on multi-payer alignment across programs within Medicare. Thank you very much. We will stand in recess, brief break until 10:40 Eastern Time. See you soon.
Produced by the U.S. Department of Health and Human Services.